Thank you very much. Well, there are a couple of terrific things about being at the end of the day. I tell people when I talk about what I do at the Innovations for the Underserved program that the most exciting aspects are to be able to connect with innovators about the things that they're passionate about, and to try to make connections between those innovators and the healthcare systems and the patients that those healthcare systems serve in the area that we call the underserved. So we're talking about patients on Medicaid, uninsured patients, rural and other patients who have a lot of trouble accessing care. And we're focusing we're really focusing a lot of our work in the Innovations program on trying to dramatically lower cost of care, dramatically improve access to care for those populations. So I want to start out with just a little bit of context, sort of where this program comes from. The California Healthcare Foundation is a private nonprofit foundation. We're based in Oakland, and we do about $40 million a year in grants and projects across the state with a fairly broad agenda for improving healthcare of the people of California. And I suppose that we do some of what Rushika referred to in his talk as studying the tides, but we try to be very active and very engaged and really drive impact in the healthcare system in California. In about 2006, we launched a program called Innovations for the Underserved. And what we set out to do in this program was to try to develop and promote and support lower cost models of care, to try to improve access to specialty care, and to try to improve efficiency, work with safety net providers, public hospitals, community health centers and clinics, Medicaid managed care plans, to dramatically improve care. We were really influenced by the notion of disruptive innovation. We felt like working in areas where we're often competing with non-consumption, we're serving people who are having a really difficult time getting access to basic care, that it would be really fertile ground for us to try to go out and spur these innovations. And the context that we face currently with the Affordable Care Act, I'm going to steal a line from our CEO, Mark Smith, who posted a blog on JAMA last week. The vast majority of Americans who are going to be newly covered under the ACA and the exchange-based subsidies are going to be low-income people, and they're going to come with low reimbursement rates attached. And as he sort of threw down the gauntlet to systems across the country, he asked the question, who's going to care for them? And how are we and they going to afford this care? So when we think about innovations for the underserved, and we think about the incredible potential for creating more affordable models of care, we really feel like we're at a moment where we're facing a crisis, and we're facing the need to really figure out how to provide more care to more people for the money that we have. So the goals of the Innovations for the Underserved program, as I stated, dramatically improve access to care, dramatically lower the cost of care, and measure and demonstrate impact, quality, and outcomes. And we think that's really important. I think a lot of the numbers that Rushika talked about are really compelling, and we need to think about demonstrating the fact that we can actually deliver better care for less money. We can reduce and eliminate waste. So I want to give a few examples of what we've been doing as a grant maker, because one of the things I'm going to talk about next is another approach that we're taking to work as an investor. Some of the things that we do in the world of grant making, we work in the area of policy. We launched an organization called the Center for Connected Health Policy, which actually just became the HRSA National Telehealth Policy Resource Center. We spent a lot of time over the past several years investing in and promoting innovation, the innovation ecosystem and education around innovation. And one of the things that's been the most exciting has been some partnerships we've had with Stanford, with first the biodesign program and then a new program called Design for Service Innovation that bring together students from the schools of medicine, engineering, design, and business to try to go into healthcare settings. We take them actually into low resource settings rather than Stanford Medical Center, where they'd historically done their work, and to get them to collaboratively design service innovations that would really help improve access and improve outcomes for patients. We funded a number of incubators and accelerators, the organizations that are supporting early stage companies innovating in healthcare. And a lot of the work that we do is really around thinking about new service and business models. So we've got a program that we have created called the Healthcare Interpreter Network. that is 17 hospitals, mostly public hospitals in California, that have joined together on a network that has 17 languages available, real time, immediately. We have interpreters either sitting at interpretation stations, or sometimes someone who speaks Hmong works in the accounting department at the hospital and is trained as an interpreter. And the 1 or 2 times a week when someone needs a Hmong interpreter, he'll pop up on their screen, stop doing his accounting for a moment, and do the interpretation. So really thinking about how to creatively use the resources of these public institutions to meet a really important need of language interpretation. It's a cooperative business model. It's a nonprofit, something we spun out a couple of years ago, but an interesting business model that isn't unique to the safety net, but I think takes important advantage of some of the features of safety net providers. We have a very extensive diabetic retinopathy screening network. Dr. Darkin talked a little bit about what the VA does. We have screened over 120,000 diabetics. Cameras are out in clinics around the state. The reading is done centrally by UC optometrists and ophthalmologists. We're able to provide that screening to people who just can't get access to an optometrist or ophthalmologist visit. And then finally, something we tried to do through grants, learned a lot, was the Specialty Care Safety Initiative with UC, with the 5 UC medical centers and about 43 clinics around the state. 8 different specialties, telehealth, goal of improving access to specialty care, and it was a fantastic program. The clinics learned a lot. They developed the infrastructure to do telehealth. They had the need, the demand. The UC system worked with them to provide those consults. But one of the challenges that we face with many of these projects is we learn a lot, we do a pilot, and then the program doesn't go to scale. It doesn't organically go to scale. So we had a couple of really important insights through the decade or so, 6 years since 2006, but longer time that we've been working on these programs. And one of them is that grants are a really effective tool for doing lots of things. And for a lot of stages of the innovation process, we feel really good as a grant maker that we're helping to move the field forward. But getting to scale is not one of the things that grants are the right incentive for in many cases. We also found our second big insight was that there are a lot of entrepreneurs out there and a lot of early stage companies that really want to take on the challenge of innovating for underserved populations. We're already in that environment, and it was a really interesting challenge, and has been an interesting challenge for us to find those entrepreneurs, to find those innovators, and to try to make the connections that need to be made to safety net providers, providers who care for low-income patients, so that the market could be made. So this led us to some questions, and we were really thinking about how do we find and support innovators who want to make care simpler, cheaper, and more accessible? How do we think differently about the integration of technology, design, and process? A lot of the themes we've been hearing about today. And as we have evolved this Innovations for the Underserved program, we've begun to think that mission or impact-focused investments can actually help us connect with a whole new set of innovators. We were running a program, an innovation program, and as a foundation, we weren't really able to. We didn't have mechanisms for working with the innovative for-profit or private sector companies out there who had solutions that could be really valuable for underserved patients and providers. So it got us to thinking that we could be a new type of investor. So what I wanted to do is just walk through very quickly. The tiles up on the screen represent 5 of the investments that we've made to date through our CHCF Health Innovation Fund. You've actually heard about a couple of them, or at least one of them today. Asmapolis is a company that has a sensor that sits on top of an asthma rescue inhaler, and time and date and location stamps information about when people are taking their asthma medication. What's interesting about it is when you think about using the word workflow, it doesn't interrupt the person or the patient's workflow. They don't have to sit down at the end of the night and remember when they took their medication. It happens as part of their daily life. That information is then sent up to a server and delivered back to the patients and the providers as actionable information that they can use to titrate medications, to change treatment protocols. We're piloting with one of the Dignity Health sites, Woodland, up outside of Sacramento with Asmapolis, and we've made an investment in the company, and we're doing an independent evaluation, which will be published to study the impact of the asthmapolis intervention on adherence and outcomes for those patients. Care and Sync is a technology platform that basically takes things like Project Bruce, Project Red, things you may be familiar with, that help work on the flow of patient through the hospital so that when they're discharged, there's hopefully less of a chance that they'll be readmitted because their medications haven't been reconciled or there isn't a primary care appointment set up for them. That was a paper process. It was a checklist sitting at the bottom of a patient's bed. This is one of several out there, technology platforms that makes that information much more interactive and allows people to do tasks at the same time, much more dynamic. Direct dermatology, I'm going to talk about a little bit more detail, a teledermatology company that's working with both safety net providers and commercial providers in California. Pipeline Healthcare, a really interesting company that deals with the problem that we heard about this morning of medication errors in a hospital. And what Pipeline does is provides for small, rural, and critical access hospitals who don't have either the staffing or the funding to have 24/7 pharmacy oversight. It allows them to have 24/7 access to a pharmacist to oversee nurse and physician orders before the medications are given in a hospital, so that you're not dealing with what a lot of them are now, that they find out retrospectively that it was an adult dose instead of a child dose, or that the dose was 10 times what it was supposed to be. And I just sat down last night with about 15 examples from the past few weeks where a Pipeline pharmacist had been able to intervene and really improve the quality of care delivered at those small rural hospitals. And finally, Serum is the only nonprofit in this portfolio currently, a terrific organization. Think of it as an eBay that connects unexpired medications, drugs that aren't going to be used in long-term care facilities, nursing homes, and drug companies to county pharmacies who have a hard time getting access to drugs for their patients, so that those drugs aren't destroyed, they don't go into the waste stream, and patients in those county pharmacies get access to those drugs. So a little bit more about how we think about what we invest in, our innovation fund criteria, strategic alignment. First and foremost, if we're going to invest in a company, it has to be very clearly connected with our mission to lower total cost of care and improve access to care. We set an impact threshold because we really felt like it was important that while these innovations are not of the totality that Ruchika talked about, that attack payment and delivery, we wanted them to be meaningful and of a big enough magnitude to have impact in California. So we want to see access for 100,000 Californians, greatly improved or new access, or we want to see a pretty strong hypothesis about how they'll deliver $25 million in annual cost savings. Most importantly, the primary reason we're doing this is we want to see potential for scale and sustainability. Grants are terrific for testing and piloting, and sometimes some of the things we've done through grants are sustainable, but really looking at these as opportunities to ensure that a market is there that will keep this innovation going through the system. And then finally, we're looking for management teams that are capable of carrying that out. So a little bit of context about why a foundation might do this, or why it's important to think about how foundations might invest. These are some statistics that I pulled there. They've held fairly steady over the past few years. U.S. philanthropies endowments hold about $640 billion. If we deployed 5% of this to mission-focused investments that are consistent with what those foundations exist to do or trying to do, that would be about $32 billion. Venture capital funds invested a total of $29.5 billion in 2011. So when people ask us the question of, why do you need to be out there investing in these companies? There's lots of capital out there chasing good ideas in healthcare. I think it's important to recognize that we're trying to really align our mission with those investments. And it's something that a lot of foundations are seeking to do now, to think about how to deploy the power of that money for mission purposes, and to try to be an investor out there that does try to drive things in the direction that we think are positive change. So thinking about the theme of this session of making connections, just a little bit about, again, what we're doing at a higher level. We're out identifying pain points in our safety net system. We spend a lot of time at clinics and hospitals and with managed care plans understanding where they're struggling. We're out spending the rest of our time identifying mission-focused innovators, innovators who have scalable businesses, who really do share our mission and share a passion for innovating for underserved populations. We provide flexible funding. We can do grants, we can do investments, we can combine grants and investments, and we do all of those things. We really think about what's the best way to try to get this innovation sustainable, try to get this innovation to scale. And I think, again, on the connection theme, we're really trying to make a market. We're trying to use our position in the California healthcare marketplace, our understanding of both sides, of the business side and of the provider side, of the plan side and the payer side, to try to find alliances and allegiances and places where people can work together and really create a new market. So I want to give one little story case example, following on the heels of the VA examples about telehealth, and focus on the impact, the access and the quality improvements, direct dermatology. This is a picture of an 8-year-old girl, and she is out in the Central Valley. And if she were to wait to see a community dermatologist, if she could find one that would see her, that wait would be about 5 months. So a big, big problem out in the Central Valley. Direct dermatology was able to see the patient in a day and get that patient seen within a week. A melanoma. The second one, a 3-year-old boy, similar, same community dermatologist wait was 5 months. Again, through telehealth, through a review of an image, they were able to see the patient in a day and able to get that patient treated, brought into a specialty center and treated. And this is something we see over and over again with this particular company that we've invested in. They started working with safety net clinics. They've expanded now throughout the state, but they're really able to, in 95% of the cases that they're seeing, handle the diagnosis, work with the primary care provider to adjust the treatment, and move these patients through a system that otherwise just doesn't have any capacity to see them. So programs like direct dermatology that started in the safety net and have a big safety net focus are one of the areas we're looking. We're also thinking about another question, and I throw this out to all of you because it's something that I'd love help from this audience with. The other question we're asking ourselves is, lots of innovations are adopted by commercial providers, by the Mayo Clinic, by Medicare, that don't make their way into institutions that are primarily funded by Medicaid or have a lot of uninsured patients. And I'm going to show you a little example of one down here. You see Holter monitor on a kid and an adult here. And this is something that you may be familiar with. It's a product by a company called iRhythm that's called the Zeo patch. And it's a data collection device that's worn for 2 weeks. The Holter monitor has a diagnostic yield. It is able to produce a diagnostic in somewhere between 10 to 30% of cases, but at the public hospital we're working with, it's less than 1%. So they're doing this, they're not getting diagnosis, and the patients are going through a diagnostic odyssey that can cost a lot of money and yield a lot of frustration for patients and providers. So one of the things we're thinking about is, how do we find devices that are simpler, that are better for providers, they're better for patients, that we hope will lower overall total cost of care in the healthcare system. And again, use our assets as a foundation, use our knowledge of policy and regulatory system, and help those migrate into systems that care for uninsured and Medicaid patients. So again, wrapping up, what do? We provide patient capital. We provide lower cost capital and more patient capital, capital that's willing to wait longer for results. We connect innovators with providers. We aggregate demand. We try to make markets out of a fragmented system so we can get all the critical access hospitals together to look at an innovation solution and give feedback. We can get in front of the 350 or so odd different community clinic corporations in California and ask them what they think about these innovations, what works for them, what doesn't. We can identify and address policy and regulatory challenges when they come up with some of these innovations through the Center for Connected Health Policy and other work. And we can measure and communicate impact. One of, I think, the most important things we can do as a foundation, as an independent voice, or a voice that's able to fund independent analyses. So what I would ask you to do is to partner with us in identifying and testing innovations and investments that can help underserved populations. So help us identify important problems that are high cost, poor access, low patient and provider satisfaction, issues that you see in your healthcare systems. Focus on viable business models, sustainability, and scale. So think about not getting in this trap of a pilot that stops at the pilot that stops when the grant funding is gone. Be really thoughtful about how to integrate technology, process, and design, how to incorporate usability by patient and providers so that things don't stagnate. And finally, be really rigorous about targeting and measuring impact. Think about the impact that we want to see, the cost reduction impact, the access improvement impact, the quality improvement impact, and think about where you see opportunities for us as a foundation and the other healthcare foundations that we work with that are interested in investing and partnering alongside you, and reach out to us and let us know where we can work together. Thanks.
Couple of things. The $29.5 billion from venture capitalists, is that in the healthcare domain?
No, that's across nationally across all domains. Healthcare is going to be $6 or $8 billion a year. Roughly.
So do you believe there is a potential $32 billion pool for mission-driven healthcare investments, or just foundation-driven investments?
I think that's a broad. You know, we're pretty narrow in the world of foundations. We work on the healthcare delivery system. We're not even, you know, next concentric circle out might be social determinants of health, community health, public health. So if you think about what a lot of foundations do, they're working on health and education and environment and you know, clean tech, a whole range of things. So that's across the spectrum.
Is there a role for traditional charity? There was a time when the hospital system in a lot of communities was purely charitable, that it relied on donations. That seems to be a discredited, unsustainable model. But nevertheless, for some problems, it may be the only way to meet some needs of the underserved. What do you make of it? I
think that's right. I think that, you know, obviously, you know, nobody feels as satisfied making a one-time donation and not seeing the, I guess, the impact of that amplified somehow. But I think there is, you know, we call it a subsidy. There's a real place for that. And I think that while it may not be the strategy or the role of foundations that are trying to sort of build bigger stories about impact, I think there are organizations and there are charities and there are faith-based organizations and community-based organizations that really are about transferring dollars or transferring services or transferring goods from one part of the community to the other. So, you know, I personally believe in that. I think to your point, it's become much less a part of what most foundations are about.
And again, I admire your portfolio of investments, and certainly your mission is worthy and valuable, but I'm concerned that the modern notion of social entrepreneurship has an implicit assumption that something that can't produce a problem that can't be addressed through a sustainable business model of some kind is not worth the investment.
You know, that's an interesting point, and I think there are domains that are more like that than others. And I think the challenge with healthcare, which is an interesting challenge, is that we have a healthcare system that is largely private providers and heavily government funded. And so we are in a domain in healthcare where lots of healthcare dollars are out there being spent. And it's not that there aren't, I don't know, maybe people would take question with this. It's not that there aren't enough dollars out there being spent in healthcare. It's that we have a lot of waste and that we've got all this fragmentation. So I guess if, you know, I hear your point in some areas, I think healthcare is an area that is really ripe for mission focused.
There's low-hanging fruit.
There's low-hanging fruit, and there are big opportunities because, you know, when you think about why people go into healthcare, everybody in this room went into healthcare to make a difference and improve the healthcare system. And whether they're in a private sector for-profit company or at a, you know, big healthcare institution, whether it's nonprofit or for-profit, or even if they're doing healthcare, in financial investing, what most of them are trying to do is make a difference, improve care, improve the quality of lives of people. And so I think that healthcare may be an area where influence and push from organizations that are really thinking about how do we take this big population of people that are now going to have some government and private sector funding attached to them and be able to deliver care within those parameters.
And the maximum
and not have
possible.
not have
Right.
the government healthcare program have to be charity because we can't figure out how to manage within the constraints of that budget.
Great. Margaret, thanks so much.
Thanks very much.